Hey everyone, and welcome to today's Explainer. We're putting on our medical detective hats today because we are going to decode one of the most frustrating, unpredictable, and honestly, sometimes downright dangerous mysteries the human body can throw at us. We're talking about the sudden appearance of intensely itchy welts and deep tissue swelling. So we'll be investigating the exact mechanisms of urticaria, which you probably know as hives, and its deeper, darker counterpart, angioedema.
Now, let's dive right into this with a pretty staggering statistic. Have you ever wondered why 1 in 5 people suddenly erupts in mysterious, itchy welts at some point in their lives? 20% of the entire population will experience this. It's incredibly common, yet the trigger often feels like a phantom. It just appears out of nowhere and vanishes just as quickly. Our job today is to track down exactly why that happens.
Here's our agenda for today. 1. Decoding urticaria basics. 2. Acute versus chronic triggers. 3. Diagnosing the itch. 4. Management and treatment options. 5. Deep swelling, understanding angioedema. And finally, 6. Recognizing medical emergencies.
All right, starting with Section 1, Decoding Urticaria Basics.
So what exactly is urticaria? At its core, it's a vascular reaction happening right in the superficial dermis, so the very upper layer of your skin. It presents as these intensely itchy, well-defined erythematosus plaques, which we call wheals. What's fascinating to learn from a diagnostic standpoint is how they behave. If you press on them, they blanch, they turn white, they enlarge, and then completely on their own, they regress and disappear within 24 hours without leaving a single trace of hyperpigmentation behind. It's literally the ultimate hit-and-run crime on your skin.
The actual mechanism behind this hit and run is the histamine dump. And this happens through 2 very distinct pathways. First, you've got the classic allergic pathway. This is an IgE-mediated hypersensitivity. Your body encountered an allergen, got sensitized to it, and now, upon a second exposure, it triggers your mast cells to just dump histamine. But the alternative is the non-allergic or pseudo-allergic pathway. And it's wild to discover that this doesn't require any prior sensitization at all. Certain drugs like aspirin and NSAIDs, or even physical stimuli, can totally bypass the whole allergy process. They directly force the mast cell's security guards to degranulate and release histamine. No prior exposure needed whatsoever, but the result on your skin? Exactly the same.
Moving on to Section 2, Acute versus Chronic Triggers.
When trying to pin down the trigger, time is actually our best clue. 70% of urticaria cases are acute, meaning these periodic outbreaks will completely resolve in under 6 weeks. The remaining 30%, however, are chronic. These are the tough cases, where a patient suffers from hives appearing multiple days a week for more than 6 weeks straight.
So who are the usual suspects here? For acute cases, the triggers are often foods, drugs, or infections. In fact, you might be surprised to hear that the most common cause of acute urticaria in children is actually viral infections. But the chronic cases are where the mystery really deepens. Over 50% of chronic spontaneous cases are idiopathic, which is just a fancy medical way of saying we simply don't know the cause. Though some are tied to autoimmune diseases like Hashimoto's thyroiditis. And then there's chronic inducible urticaria. These are fascinating physical triggers. You've got dermographism, which literally translates to right on skin, where a simple scratch causes a wheal within seconds, or cholinergic urticaria, which is triggered just by sweating from a workout or taking a hot shower. It's crazy to think that your own sweat, or even just the pressure from a tight waistband, can literally be the trigger.
All right, let's get into Section 3, Diagnosing the itch. This is where the real detective work happens. The most crucial thing to understand about diagnosis is that urticaria is overwhelmingly a clinical diagnosis. Step 1, and the most powerful tool in the arsenal, is the patient's history. Because hives disappear so incredibly fast, Step 2 is vital, visual evidence. If a patient breaks out, they need to grab their phone and take photos. That camera roll is often a doctor's absolute best diagnostic tool because patients usually show up to the office with perfectly clear skin. Step 3 is targeted testing, and I mean highly specific. We only test based on a strong clinical suspicion, maybe checking for physical provocation like scratching the skin to literally prove dermographism right there in the clinic.
And that brings us to a massive misconception, one that can save patients a ton of time, stress, and money. Routine lab work and massive allergy skin prick testing panels, they are generally a huge red herring. They are basically unhelpful for chronic idiopathic urticaria. Unless the patient's history specifically points to a type 1 hypersensitivity, like eating a peanut and immediately breaking out, broad, untargeted allergy testing usually just leads to dead ends and totally unnecessary dietary restrictions. Trusting the clinical history over a battery of expensive tests is absolutely key to an effective diagnosis. Now, another crucial part of diagnosing is making sure we're actually dealing with urticaria and not an imposter. We have to suspect a mimic, like urticarial vasculitis, if the lesions start breaking the rules. You want to pay really close attention to these warning signs. Do the lesions stick around for more than 24 hours in the exact same spot? Are they painful or burning rather than just itchy? Do they leave a dark mark or residual pigmentation when they finally fade? Do they totally ignore antihistamines, or maybe bring along systemic symptoms like fever and weight loss? If you're seeing these signs, you aren't dealing with simple hives, and it completely changes the clinical management.
Section 4. Management and treatment options.
Before we jump into medications, let's look at a highly reassuring number: 50%. Even if a patient is dealing with chronic spontaneous urticaria, that incredibly frustrating kind that lasts for months with absolutely no known cause, 50% of these cases are entirely self-limiting. They will resolve completely on their own within 1 year. The body just eventually resets its own security alarms.
But of course, while we wait for that reset, we need a solid first-line defense. For management, the absolute primary weapon is the second-generation H1 antihistamine. Think drugs like loratadine. Why specifically second generation? Well, because they do an amazing job blocking the H1 histamine receptors, which shuts down the itch, the redness, and the swelling. But crucially, they do it with significantly less of a sedative effect than the older first-generation drugs. You want to stop the patient's itch, you definitely don't want to put them to sleep all day. It's a fundamental part of smart, effective management.
Section 5. Deep swelling. Understanding angioedema.
To really grasp angioedema, we have to compare the surface to the deep tissues. Urticaria happens in the superficial dermis, the shallow waters of the skin, right? It's itchy, it's red, it's well-defined. Angioedema is a vascular reaction happening much deeper, way down in the subcutaneous or submucosal tissues. Because it's so deep, it doesn't present as an itchy welt. Instead, it presents as a sudden and far more dangerous, non-pitting swelling. You'll typically see this really impacting the face, like the lips and eyelids, and most critically, it can hit the larynx or the gastrointestinal tract, which causes severe abdominal pain or life-threatening respiratory distress.
Now, here is a massive distinction for management. Not all angioedema is created equal. There are two very different paths. The first is histamine-mediated. This is essentially the exact same allergic mechanism as urticaria, just happening deeper. And because of that, it will respond to standard therapy like antihistamines and steroids. But the second path? That's bradykinin-mediated, and this is a completely different ballgame. It's driven by a buildup of bradykinin, which is often due to a genetic C1 inhibitor deficiency, or super commonly, it's triggered by ACE inhibitors, which are a very standard type of blood pressure medication. Here is the vital takeaway for management. Bradykinin-mediated angioedema usually happens without any itchy hives at all, and it will absolutely not respond to antihistamines. It requires entirely distinct, specialized emergency treatments, or, if it's from medications, immediately stopping that ACE inhibitor.
Section 6. Recognizing medical emergencies.
We absolutely have to know when a localized allergic reaction turns into a full-blown systemic failure, which is known as anaphylaxis. This is a severe, multi-system threat. Notice here that the skin and mucous systems, which present with hives and swelling, are involved in about 90% of anaphylaxis cases, so urticaria is very often the canary in the coal mine. But the true immediate danger lies when it hits the other systems: the lungs suffering from wheezing and shortness of breath, the throat physically closing off, the cardiovascular system crashing and causing a weak pulse, or even cardiac arrest, and violent gastrointestinal cramps.
If a patient presents with those multi-system symptoms, standard antihistamines are completely off the table. They are no longer the priority. The emergency protocol kicks in immediately. The ABCDE approach, checking airway, breathing, circulation, disability, and exposure, is vital. And the absolute, non-negotiable first-line therapy to reverse this systemic failure is intramuscular epinephrine, supported by IV fluids and oxygen. Literally nothing else works as fast or as effectively to save a life in this scenario.
All right, let's summarize our investigation with these core take-home points. Urticaria is a superficial, temporary vascular reaction. For diagnosis, your best tools are a rock-solid clinical history and photographic evidence. Definitely not massive, untargeted lab panels. When it comes to management, you want to reach for oral second-generation H1 antihistamines as your primary defense. And above all else, always remain vigilant for the deeper threat of angioedema and the systemic emergency of anaphylaxis.
I want to leave you with this provocative thought as we wrap up this explainer. Think about it. Our immune system is an absolute marvel of nature. It's sophisticated enough to hunt down and neutralize lethal, rapidly mutating pathogens. Yet, as we've seen today, it can also inexplicably launch a massive, intensely itchy, and sometimes life-threatening attack against a harmless ice cube, the pressure of a tight waistband, or even just a single drop of our own sweat. It's a pretty fascinating paradox of human biology, and a great reminder that there are still so many mysteries left for the medical detectives of the future to solve. Thanks so much for joining me on this deep dive.